So what I'll do is, you want to have a quick tour around the building, and then you can maybe come back and get any questions.
Who does run all the drug treatment orders and that now then? Is it just directly through probation or? Right.
Yeah. However, I have got a criminal justice team here in this building as well, so they liaise directly with them. The DIP service runs from here, as does the rest of the criminal justice service, and they can refer directly into my service. It's great having everyone in the same building. Yeah. Because if someone's been, say they've just come out of prison, they've been receiving a script in prison, they come out, they stay with the DIP team for maybe a month, but they're really stable, they can say, right, straight into my team. Yeah. So my guys can just take them straight on. There's none of this referring, sending DARs across the country or across different parts of the city. But yeah, we're all in the same building.
Because that's something, I've worked up in Bristol in bail accommodation, and people coming out of prison having got clean and got on a regime and then just being left with nothing.
Yeah, totally.
So
now I think, especially with the new IDTS around that, is working well. Integrated drug treatment service, people from the prisons, within the prison service and from the prison culture coming out into, it's a link, a continual link now. So if someone's on a script in prison, they'll come out, and if the system's working properly, there'll be a script waiting for them straight away, already in place, everything should be in place for them. It's what DIP was originally brought in for, however DIP ended up getting used for lots of different things. DIP, Drug Intervention Program, but this is just like they've enhanced the DIP package, and I think it's brilliant, really good. We have as EDP and Devon Drug Service, we have workers in the prison who work for the same organisation as me. We have workers in the community teams, we have workers in the criminal justice service, all in the same organisation, which helps so much that we're all in the same organisation, because communication's really open in there. So a client could see one of EDP's staff in prison that day. They'll come out, report to the police station and say, I see another one of our staff, and they'll walk them here. And that's it. It's continual treatment.
Does that help with trust as well?
Totally. Yeah. The fact that the client sees a relationship with us, sees that we have a relationship.
And the fact that you're a non-statutory service helps too, does it?
Loaded question.
It's true in many other. I don't know anything about drugs and alcohol, but it's true in lots of fields that perhaps there is less reluctance to engage with people that aren't perhaps part of the statutory services.
I've worked in both. I've worked in the council in East London. I've worked with a company called WDP in London. I've worked here. It's not about that. It's about the service you provide
and the people.
It's not about who you work for or whatever. It's about what service is being provided. The service I worked for in East London for the council was a great service.
So it's just purely about the quality.
Yeah. Totally. Yeah. But that becomes around resources, doesn't it? I mean, some councils or whatever might not give you the resources you want, or understand the resources you want people working to do.
So does each individual have a programme of visits, or do the group have visits, or how does it work?
What happens is we'll tailor it to the individual. Right. If someone, clearly workshops don't work for everyone. However, every one of these workshops can be run on a one-to-one. We have workbooks for every single workshop, and that workbook can be done as a workshop, or it can be done on a one-to-one basis. So, because we're a community drug service, some people obviously very much here in Exeter as well hold down jobs and manage that quite successfully. And so they can't come into workshops when we're in their workshops, or whatever. And so that we'll arrange to see them in the evening and do it through one-to-ones with them. At the moment, we're only open one evening a week. However, I can see that changing in the near future. But around the individual. It's not anymore. It used to be, you come into the drug service, you get put onto a script, you don't turn up for your appointments, your punishment is you get taken off your script. And that was the drug, and that's how we ended up with so many people trying from film. So many people on methadone scripts for years and years and years. You know, I mean, there are people on methadone scripts that have been on for 20 years. However, the idea now, and we're starting to be very successful at it, is treatment is, and the service user, it's a model where it's what suits you, it's what's best for you as a service user, and for us as a service. And what we also want, everyone now has to go through some form, we have to evidence some form of progress.
I was going to say,
what this is about.
How do you do that? Do you take a measurement of somebody's cognitive attitude or whatever at the beginning, and then midpoint, and then at the end, and then the benefits to them may not necessarily be a reduction in the drugs that they're taking at that particular time,
but their life could be
their
completely
lifestyle's
enhanced.
Changing. Yeah.
What about the social spectrum? What do you cover? The whole of the social spectrum?
We cover.
Or do you have a block of lower, middle, or upper, or is it across the section?
Everyone. It's whoever, especially this part of the service. Anyone who turns up and asks for treatment. I see, for instance, a lot of people, maybe businessmen or whatever, might not want to come here. Might not want to come and sit in a waiting room with someone who's street homeless, or they may, you know. However, that's when the mobile unit comes in, really effective. We will go out. We won't just set up in car parks. We'll go to someone's house if necessary. We'll do risk assessments on all that sort of stuff, obviously, make sure it is safe for them and us. You know. But we will see anyone and everyone. My time, I've worked with pilots to street homeless. I've worked, you know, with that. And there's no reason why we shouldn't. Media maybe sells a different story about drug users.
Is the staff voluntary and paid? Are they CRB rated?
Yes,
Yeah.
everyone. Yeah, can't work on a service unless they are.
No, that's why I asked the question.
Yes.
How do you think with other services, obviously people need this kind of support,
Yep.
in giving them this kind of support they might need support in other areas, whether it's education or mental health or whatever. How do you kind of link up with the other services that are available?
For instance, what day is it today? Wednesday, Monday I had Job Centre Plus in here, working with clients, because they have a different way of referring into treatment, and they refer into us. So we have a good link on Job Centre Plus now. We also will refer on to different agencies. The idea of the new Devon Drug Service programme, it's set up now, but it's a 3-year model, and we're in year 1 at the moment of the new design. In year 2 and year 3, we want other agencies to come into, rather than us just signposting out, and we want them involved in the part of Devon Drug Service. So Devon Drug Service will have housing, who come here every week, and whatever that be, and education, everything. At the moment, the support workers and care coordinators, that's where the support workers come in really handy. They will take people to appointments at different places. And also, so it doesn't cost the client anything to get there, because we're running there. And also, any client who comes here for treatment, they get all their travel expenses back as well. So we do everything we can. And if a client isn't turning up for an appointment, that's where the old school was, you're not turning up for your appointment, so, you know, we're going to stop the script. What happens now is it's okay, why aren't you turning up for your appointment? What can we do to make that better? And it could be something as simple as childcare issues. And so we'll work with that and then make sure we do everything we can to make it work for the service user. But not always going to happen. And obviously there are going to be people that decide then, or it isn't ready, they're not ready for it yet. They're not in a place where they can, you know, commit to recovery in any way or any sort of harm reduction. They're not there. But as long as we can evidence, we've done everything we can, and we do, then we're doing what we should do.
Do you think rurality is important? Do you find that most of your service users live in big towns, or is there something about rurality as well with people in drug use? And we're just talking about accessing services as well, but
well, what we do notice is you obviously have trends and patterns in somewhere like Devon, sort of rurality. For instance, legal highs. I could pickpocket you about 4 different locations where legal highs, and I can tell you exactly what the problem would be, what the main legal high would be about 2 months ago. Pockets of stuff which was getting sold because that's the shops in those areas were so it became an issue in those areas. Depends on the dealers that are out there, where they're dealing, what they've got. You definitely you can see pockets of interest, which is how we, obviously as part of how we decide where we send our mobile. Our mobile unit isn't fixed to any one area. I'll change it if necessary. We say, okay, we've got something going on with this, let's go out there for a while. I have specific areas I'd like it to go in, but then if we've got something going on, and the clients, believe me, tell us. We don't need to do the research. They'll come and tell us.
I know I had a lad once who'd come down from Bristol and they got sent to a town in Devon because they thought that he was going to be safe there, and it's just as prevalent there as in Bristol.
So how do you publicise the fact that you have this mobile unit going somewhere?
Well,
how do the people in those areas know that there is going to be a visit from you?
It's a very good question, and it's something, when we set this up, it's been running, I'd say about 1.5 years now on mobile. We thought, how are we going to do this? Because
you can't go there with a big board, can you?
We can't. And it took me a lot of persuasion to some of the councils and areas to actually be allowed to put posters up in public toilets even. Massive no at first. The best way and the most effective way is actually through the clients. We're going to say to one client, the clients come to us, as I said, they give us the information, they say to us, there's a problem up in so-and-so. So we go, okay, and then we'll say, right, we're going to go up there, and I'll tell the mates then. And that's how it works. We do, however...
By word of mouth.
Yeah. However, we do advertise in the chemists, which are providing needle exchanges in those areas. But you wouldn't know that we're advertising, the average person, because the advertisements which we use, it's a symbol that the clients know what it is, and actually my mobile van's out today. I was going to get you to have a look at it, and you would. It's literally a VW camper van full of equipment for needle exchanges, and that's not all we use it for. It's actually just a direct access unit, really. But there's literally a sign on the side of a sign that big, and a sign of the van with an arrow going that way and an arrow going that way. And the clients know what that is. Yeah. They know that's needle exchange. And the same symbol is in the chemists that do needle exchange with the timings and where we will be.
Interesting.
Yeah. I was going to say, if you're too blatant about it, you must get problems with sort of NIMBYism and
totally, totally, you'll get problems from communities going, no, not here. Rightfully so. Everyone has their right to get up and say that. However, if we can say, well, actually, it's been running in your area for the last year, and what we have done is the police have reported back to us where there's, for instance, a lot of needles being found in certain shopping centres around the backs of the recycling bins and all that stuff. So we've targeted those areas, and we've reduced the amount of needles that are getting left behind, because the clients are then coming to the van, exchanging their needles, getting clean gear, we get rid of the old stuff for them, and we've been reducing the amount of needles that are found in locations and stuff like that. So they're actually, it's a real positive. And it is quite controversial to some people, needle exchange. Aren't you encouraging people to use drugs? But it's the best way of getting people into treatment. We're not judging them. We're saying, do you know what? If it's about harm reduction. Here's some clean gear for you. But my staff are so skilled in in when it comes to that interaction of here's some clean needles. Why are you using no wet needles? Where are you injecting? If you want to inject safely, you need to be using these needles. There are lots of different needles. I'll show you some in a minute.
Needle fail.
However, that interaction builds and builds and builds, and I can give you lists of names, but I can't. But of people that have started off an interaction like that and are now drug free because they've come through the system, and my guys have just taught them, well, try coming to a workshop, try this, try that, and within a year they're been out, went 6 months with us, they've been out to rehab for 6 months, and now they're living a completely different life.
You've given us a fair rundown on the drug abuse. What about alcohol?
Alcohol is a legal substance, however people abuse it. We work here with clients that are drug dependent and abuse alcohol. However, if a client comes to us and it's only an alcohol issue, nothing else, then we would refer them into addiction, which is a different service.
Right. But you don't turn them away.
No.
But there's the level of funding for alcohol services is much less than the level of funding for drug services. But obviously because of the criminal side of things, I would have thought, and the destructive behaviour, I guess. But I've just done a little bit of research about it in Devon, and it's the numbers of people drinking hazardously compared to problematic drug use. It's vastly different. I mean, there's 100,000 difference or something, but the funding isn't there for the treatment of hazardous drinkers, and I just don't know why. What could be done about that? I mean, and why is it proportionately so much less? I know it's probably a question you can't answer, but it's when you look at the figures, it's...
What I can say is the years I've been working in this field, it's always been an issue.
Yeah.
However, our funding, a lot of our funding comes around criminal behaviour.
Yeah.
And criminal behaviour is related to heroin and crack. And so that's where a lot of the funding comes from.
I do appreciate it's just when you look at the black and white figures, the difference between...
Well, it's like that report that's just come out, hasn't it? They want to upgrade alcohol in terms of the kind of classification of drug it is, and downgrade some of the other ones based on the level of harm that it causes within society. But the government doesn't seem to listen to that.
I worked in rehabs as a counsellor, and the one job we would all try and do everything we could not to do was when clients come into the rehab, they would spend the first few nights in a little hospital room doing their detox, an alcohol detox. We would all avoid it because we didn't want anything to do with that, because it was horrible. Seeing someone going through an alcohol, it's horrible anyway. Any detox, but going through withdrawals from alcohol, one, it's very, very, very dangerous if it's not done properly, and just seeing someone go through it, it's horrific.
What's the kind of the level of the problem in sort of Devon and the area that you cover? What are the kind of numbers that you're talking about?
I haven't got the numbers here. There is an issue. There is a problem in Exeter and Devon.
Is it going up, down, staying about the same?
I guess it's about the same as it has been since I've been here the last couple of years. As I said, I came from London, working in the East End of London. Expecting when I came here to be a very different drug service, very different approach. And actually the only real difference that I've noticed, no figures to back this up, is this is just less violent crime related to drugs. That's the only real difference. Everything that was around in London is around here. Historically they say there's more of an amphetamine problem in the West Country. And less crack than there is anywhere else in the country. Maybe it's changing a little bit that now, but that's historically what it's said, and that could go back to many different reasons. There's different theories behind that. It could be related to fishing culture and people out at sea using amphetamines. I don't know.
Well, it's just boring.